Hi, welcome to Nutritional Medicines by Lab Analysis. My name is Dr. Cyrus Thomas. I've been a chiropractic physician practicing nutrition and homeopathic medicine for 34 years now, and have done about 350 of these TV shows wherever I've lived. And today we're going to talk about hormones, male hormones, female hormones, how to test for them, and what signs and symptoms you could have that may indicate that you have an imbalance with your own hormones. So if you've wondered if your condition is hormonal, watch the show. I will get you information, and at any time you can call our number. We can get you a doctor near you so that you can find out what testing you need, and hopefully you'll be educated so that when the test results come back, you'll be able to discuss with your physician what those results mean. A hormone is a molecule. What is a molecule? A molecule is just a few atoms put together. We put it together, a few different atoms. You get this configuration in space of several atoms. We call it a molecule. A hormone is a molecule. And it goes around in the blood, and it attaches to certain parts in the body, and when that attachment takes place, the thing it attaches to knows that it is supposed to do something different. So that hormone acts like a messenger in the blood, and there's two main ways of getting messages around the body. And one, of course, is from your brain, sends a signal through a nerve, goes out your arm, goes to your liver, goes to wherever. And that when that signal gets to its endpoint, that endpoint object, be it a muscle or an organ, knows to do something different. That's a very quick way of getting messages around the body. A slower way is by hormones. And we have glands that make hormones. They're called endocrine glands. And they secrete hormones, the molecules, into the blood. They eventually mix with all the blood in your body, and they're giving messages to different things. Now, for example, the hormone glucagon and insulin made in your pancreas, they tell your liver what to do in terms of how much sugar to release, how much sugar to make, how much sugar to convert. But some other hormones, like insulin is also one of these, but the thyroid hormone goes to every cell in the body and tells that cell how fast it should metabolize, how fast it should do chemical reactions. So some hormones are very specific to the area that they talk to. Others affect every cell in the body. Now, the thyroid, one hormone made by the pituitary gland, endocrine gland, in the base of your brain, makes a hormone, a thyroid stimulating hormone, that only talks to the thyroid. It just goes just a short distance, but it mixes in all the blood in your body. But it's the thyroid gland that picks up that hormone is there. It then knows to make more thyroid hormone for all the cells that are in your body. We're going to use lab analysis with blood and urine, and today we're going to talk about saliva testing for hormones and why that's superior to testing hormones in the blood. One thing we can do is by saliva is a woman can test her saliva every few days. We send all of those samples into the lab, and then we can map out over a month's time what have been the rises and falls of different hormones, luteinizing hormone, follicle stimulating hormone. We're looking at the follicular phase, the luteal phase. There's where the menstrual cycle falls. And we're looking at estrogen and, of course, progesterone. Now, estrogen is orange here, goes up before the menses and drops at the menses. Progesterone, however, stays level, and right at menses it goes up through the luteal phase and then comes down again. We look to see what's in balance and what isn't. And of course, the name of this program is Nutritional Medicine. So we're going to be talking about correcting these problems, not by just throwing hormones at the body, but by getting your own endocrine glands to make the hormones that you need in a balanced way. Let's talk about that for a second. It's really, really important. Let's say, for example, your thyroid is sluggish because it lacks maybe iodine, maybe selenium. It's having trouble making enough thyroid hormone. Now, I'm taking a very complex chemical series of reactions here and simplifying it. So the pituitary gland that makes thyroid stimulating hormone says, oh my God, there's not enough thyroid hormone in the blood. Let's trigger the thyroid to make some more. So the pituitary gland secretes thyroid stimulating hormone into the blood. The thyroid picks up that messenger is now in the blood. It starts making more thyroid hormone. Well, that's the way it's supposed to work. However, if you say, well, you're not making enough hormone, thyroid hormone, we need to give you some Armour, some Synthroid, we need to give you the hormone that you need because it's low in the blood, right? So of course you should take some. Wrong. When you begin taking thyroid hormone, assuming that your thyroid can still make some hormone, then you actually tell your thyroid gland to go to sleep. It stops making the hormone that it was making because now it's coming from the outside, which we call exogenous. When we give exogenous hormones, which is hormone replacement therapy, HRT, we put endocrine glands to sleep. We think in nutrition and holistic medicine that this is really the wrong way to go. So thyroid replacement therapy, HRT, is a pretty not very thought out way to go. Now, if your thyroid hormone is completely shut down, it can't make thyroid anymore, then you have to take a thyroid hormone exogenously as hormone replacement therapy. That makes perfect sense. But when there's some thyroid still working, we want to see if we can get the thyroid gland to do what it should be doing. That's cure. That's doing good medicine. And that's what we call medicinal. A replacement therapy really isn't medicinal. Now, this is the pancreas gland in the body. The adrenal glands make hormones. They're sitting on top of the kidneys. The ovaries make hormones. The testes in the male make hormones. The pituitary gland at the base of the brain makes them as well. And the endocrine glands secrete hormones which regulate various functions throughout the body. This is just a basic review. There's the thyroid gland in the neck. Now we're going to switch here, and I'm going to go to a series of slides on an Adobe where we're going to be evaluating androgens through saliva testing. Now, what are androgens? Well, if we talk about female hormones and male hormones together as a group, they're called androgens. That's where the word androgynous comes from. I don't think the galaxy Andromeda comes from there, though, although we were joking about that the other day. Now, let's see if I can get this screen cleared up here for you. We've got an image here that we don't need, which is kind of blocking things. Maybe that will do it. So in this webinar, we're going to talk about the androgens in men, which are the male hormones, the androgens in women, the female hormones. We're going to talk about the pathway panel. What does that mean? Well, when we look at a panel that describes a pathway, we're talking about one molecule that is eventually going to become a hormone. That molecule gets changed a few times in the body to become a hormone. Sometimes to make those changes, we need what are called catalysts. Those catalysts are known as vitamins, sometimes minerals, sometimes amino acids, sometimes enzymes. All of those things at different places in the body at different times turn one molecule into another. If you're missing that catalyst molecule, you can't complete the pathway. So we have to study the pathway to see where did it break down in the sequence of events that needed to take place for the manufacture of that hormone. That's self-explanatory. We'll go to talking about some androgens. Here is progesterone and what makes what. Of course, progesterone can go straight to progesterone, but most of the androgens are made from cholesterol, believe it or not, a fatty molecule, and hormones are made from fat. So when we take pharmaceutical drugs that reduce our cholesterol, we are playing around with the source of material that makes our hormones. We're also playing around with the lining of every cell in the body, which is made of fat. So our cell linings and our hormones come from cholesterol. Besides, cholesterol is the slipperiest substance known to man. We need it to be able to have oil in the blood to move red blood cells through skinny little capillaries. If you reduce the oil, you can't move things around as well. Your body then knows to increase the blood pressure. Now you have to take blood pressure medication. Then that stops the work so well. So then we use a blood thinner, and it goes on, and a diuretic. And before you know it, you're on 7 or 8 meds for a problem you should have left alone in the beginning. Now, you can get androgens endogenously from your body. You can get them exogenously from outside. Now, from outside, it can be in the form of bioidentical hormones, which is probably better than synthetics, but you're still encouraging that endocrine gland to not do what it should. Endogenously, we have what are called precursors. So DHEA is a precursor. It's a molecule, and if there aren't a lot of DHEA molecules in the blood, you can't make hormones from it. So you need more DHEA, which you can either consume straight in, and now you've got the precursor, but then again, we're not really curing the problem. We're not curing the problem unless it can work on its own without interference. What we want to do is give substances that should be in our food that allow you to make your own, have enough of your own DHEA, instead of just supplying it for you. That would be DHEA replacement therapy. We're back to the same philosophical problem of not getting your body to make it itself. Androgen metabolism and action. What we're looking at here is we're saying that testosterone, is important for bone formation, muscle mass, and making sperm. We're also, it also, when changed by 5-alpha reductase, becomes dihydrotestosterone, DHT, and is important for external genitalia growth, prostate growth. It can be involved in acne, facial body hair not being where it should, and scalp hair loss. Now, if we take testosterone and use aromatase, an enzyme, we can get estradiol, and estradiol can be involved in bone resorption, hypothalamic, which is a gland in your brain, involvement, gynecomastia, which is a formation of breasts in males. So one molecule, testosterone, is not just a simple picture. It does many things in the body, and it can be made into different things, DHT or estradiol, and it can become other things. That's why testosterone is also important for women, because its connection with estradiol, which is very close to estrogen. Serum versus saliva. Why should we? Serum, by the way, is the clear fluid that's in the blood. So that when you draw the blood and you do a blood test, before you do the testing on the blood, you spin the blood in a centrifuge. The gravity pulls all the red blood cells to the bottom of the test tube. That's about 40% of what was in there. The top 60% is a clearer fluid we call serum. So serum is the part of the blood that is not made up of white blood cells. Why should we test the saliva for hormones instead of serum? Well, The manner in which most serum assays for total testosterone and free testosterone are currently performed is decidedly unsatisfactory. There are important discrepancies and inconsistencies in serum-free and total testosterone. All serum hormone testing needs to be questioned. According to, these are all different sources. The accuracy of saliva testosterone is 98.5 to 100% for assessing androgen deficiency. It's clear that saliva testing is the way to do it. What kind of problems do men get when their male hormones, their androgens, are out of balance? They can have erectile dysfunction, reduced libido, fatigue, reduced fertility, andropause, which essentially is male menopause, muscle atrophy, and apathy. They can have urinary problems, a loss of masculinization. They can get acne. They can get hair loss. Estrogen and progesterone problems in men can lead to breast enlargement, gynecomastia. Also, too much marijuana over a long number of years can cause gynecomastia. Mood, lability, reduced libido, weight gain, urinary problems, adrenal problems. Of course, the adrenal glands make adrenaline, and we need that for fight and flight and heart control and all kinds of things. What kind of hormone problems in women do we find? Hair growth, also known as hirsutism, acne, oily skin, irritability, defeminization or masculinization, hair loss, reduced libido, weight gain, fatigue. So a lot of the problems that a lot of people have are hormone related. Here's an example of acne where the androgens increase the sebum production in the sebaceous glands, making for oily skin and increased rates of acne. No fun, that. We won't go over this in detail, but this is a flow chart for the doctor to use in understanding hair formation or hirsutism and figuring out what hormones at what positions can be implicated. Now, hirsutism comes in many different ways. Growth in the chest where it shouldn't be, growth on the legs, growth on the arms, growth along the back in women, and it can be too much growth above the umbilicus as well, and it can happen under the nose on the face. When we're talking about estrogen and progesterone in women, here are some of the symptoms that come up: hot flashes, night sweats, vaginal dryness, bone density loss, painful cycles, fatigue, mood lability, reduced libido, weight gain, reduced fertility, abnormal cycles, as in menstrual, and sleep disturbance. Quite a common array of symptoms that people have. Now, when we do an androgen pathway panel, these are complicated, but remember we talked about cholesterol making pregnenolone, which makes DHEA. The DHEA or the pregnenolone can make progesterone and androstenedione, which makes estrone. Estrone can be exchanged for estradiol, and androstenedione can exchange for testosterone and DHT. So when we test all of these substances in the saliva, we know where the culprit is. The breakdown is in the pathway, and we'll look at that again in a moment. Here are some common symptoms and the codes that we use in billing insurance: fatigue, low libido, mood lability, erectile dysfunction, hair loss, hair growth, acne, infertility, difficulty in urination, increased urination frequency, a common symptom of men, and menopausal symptoms. Control in men. How does this work in the male? Well, in the testicle, we have production. In the pituitary, we also have production. The anterior pituitary is making luteinizing hormone and follicle stimulating hormone. And the hypothalamus is affecting the pituitary gland. These hormones then leave the pituitary, go into the blood, and affect the testicles. In the woman, it's similar. The hypothalamus at the base of the brain is also involved, as is the pituitary endocrine gland at the base of the brain, making the same hormones, luteinizing and follicle stimulating. And those hormones are affecting the ovaries. The ovaries are making estradiol and progesterone. Follicle-stimulating hormone and luteinizing hormone testing is pertinent in fertility, menopause, andropause, male menopause, exposure to exogenous substances, pituitary abnormalities, mental health, and therapy decisions. When we're looking at it in the male, we can say that infertility affects 5 million couples in the U.S. The female is responsible for about 58% of those, the male's 25%, and unexplained is a high 17%. When it's involving the male, we have different causes. The testes can be too small for a primary or secondary reason. Transportation of sperm can be affected, and 40 to 50% is unknown. That's why results are so poor in fertility clinics. When we look at this in the female, here now we're this is the same as the previous slide. Now we're going from the female causes of 58%. It can be problems with the ovaries, with the tube, with endometriosis or abnormal growth in endometrium, which is in the cervix, and other is 7%. Again, we have pituitary causes, we have ovary causes, and uterine or outflow tract disorder, 7%. So a host of reasons here. Patterns in a panel, we're looking at exogenous endocrine disruptors. We did a show on that. I did a show on that a couple of weeks ago. And when we're talking about exogenous endocrine disruptors, we're talking about toxins in our environment and in our food, especially processed food, and in a suntan lotion that actually are hormone blockers. We called them hormone blockers for years, and now we call them endocrine disruptors. These are chemicals, toxins that come into our body, go into our blood, and actually disrupt the hormones that are in our blood, making us think we have all of these hormone problems, but what we really have are endocrine disruptors that came about exogenously from the outside environment in. Another problem is polycystic ovaries. Polycystic ovary syndrome, a real bad problem. We can take a look at that right here. Well, we will in a minute. Now, if we're looking at exogenous substances, we can use a color coding system to determine where the biggest problem is in the chain of molecular events, right, leading to the production of hormones. We need to know exactly where the weakest link is in the chain so that we can correct it nutritionally. Same thing here, we're looking at estradiol, we're looking at progesterone, and we find the hot spots in the test, then we know where to go. This is a case of exogenous, from the outside, substance use. A 63-year-old man was complaining of low energy, skin lacks tone, but he uses his wife's topical progesterone. These were his test results. The red part showed up the biggest problems for him. And he was given a detox treatment plan. He was to discontinue the progesterone use, of course. We did some liver cleansing protocol. He was given fiber, herbal formula of Silybum, Thyraxicum, Arctium, and Rumex, and we increased water intake and retested in 3 months. And then the results showed a much better test with less red. So a case of an acquired hypogonadism. That's when the testicles are just too small in a 29-year-old complaining of low energy, consistently low serum testosterone, a history of anabolic steroid use, and diminished testicular size. How do you know testicular size is diminished? Well, you can go online and find this as well. These are actually the size of the testicle from the age of 1 through the age of 25 when growth normally stops. Person can do a self-exam for that. We tested pathways. We found red in the estradiol. Treatment plan for atrophy, vitamin E, selenium, and zinc, CoQ10, alpha-lipoic acid, aromatase inhibitors. Aromatase helps to make estrogen. Orchic and pituitary glandular issues. Testosterone can be given. We retested in 3 to 4 months, and you can see the bright red is gone. This is a case of polycystic ovarian syndrome. You can see the cysts in the dark. That's using ultrasound. Her test results, she had a lot of red. Treatment plan was to optimize her BMI, balance glucose metabolism, herbal formulas, liver cleansing. This is the way we get people well. Let's go back to our PowerPoint presentation. So the point is, I hope you have gotten something good from this, and we want to educate as well as here we go. We want to educate as well as inform you with information that you can take to your practitioner, so that you sound intelligent and that you know what's going on. That's important to do. For more information on what was discussed on this show, or to find a doctor practitioner near you, you can go to integrativealternativemedicines.info. That's medicines with an S. That's a big website. You'll be able to find a link to see many more of these shows there as well. Or call 415-847-5020. We'll get you information. We'll get you somebody that can help you with this. And what I'd like to do more than anything else is that wish that you be in good health. Thanks for watching.